I'd like to welcome you to today's special Quality Month keynote address. Our guest speaker is going to be Dr. John Toussaint. He's an internist. He's former CEO or CEO Emeritus for ThedaCare, which is an organization in Appleton, Wisconsin. He's currently CEO of Catalysis, which was formerly called ThedaCare Center for Healthcare Value. He was founding chair of the Wisconsin Collaborative for Healthcare Quality, so certainly reflects on the work he's going to talk about with us on quality. And while his work has been focused on healthcare, he was elected in 2012 to the Association for Manufacturing Excellence Hall of Fame, which includes some other people we've had as speakers here, John Womack and John Shook, who preceded and followed Dr. Toussaint in that prestigious organization. I personally met John for the first time earlier this morning as he was rounding, coming from the cardiovascular center. I briefly met him in the hallway by the CVC. But he spent the greater part of his career pioneering the infusion of lean and problem-solving thinking into healthcare. As many of you know, ThedaCare has been a major regional healthcare leader. And he's been a leader in using lean principles to really help us all improve the care that we provide to our patients in terms of what they deserve. Under his leadership, Catalysis has really been dedicated to inspiring and accelerating change to others. They've recently been working with many CEOs in terms of a collaborative of CEOs to learn about lean and to work together to become better practitioners of lean and better leaders for their healthcare organization. John's also the author of 3 books, including On the Mend, Revolutionizing Healthcare to Save Lives and Transform the Industry. And he's really managed to make continuous improvement something embedded both in his organization and many other organizations. I think it's something we all aspire to here at the University of Michigan. But as Jack Billy has said to me many times, we're all on a journey, and we will always be learning and trying to improve what we do. Today, John's going to talk to us about 5 qualities, or what he terms behavioral dimensions, that he and his colleagues have identified that are critical for promoting a culture of continuous improvement. Most importantly, this work emphasizes the need to seek out the contributions and thoughts of our frontline personnel. So I'm so glad to see so many of you who are our frontline personnel here to hear his talk today. So without further ado, I'd like to ask Dr. Toussaint just to come up and kick off our Quality Month events.
Thanks, Dr. Bernstein. It's great to be back here at the University of Michigan. I think this is my 4th visit now. So I always enjoy coming to learn from you all. Today was my 196th GIMBA visit in 18 different countries over the last 8 years. So I guess I consider myself a student of the game, so to speak, a student always trying to learn what people are doing to make things better in their organizations. And so it's my privilege to be here to kick off this Quality Month. So let's talk a little bit about what I think is important from the standpoint of the transformation of healthcare. This is what we believe. If we could get these 3 things to happen all at once, that we could actually see true healthcare reform. So care that's designed around the patient, not around us, the doctors and nurses. Transparency of performance of how we're doing with our customers, and then payment systems that actually reward value. And as we all know, right now we're not really being rewarded for value, we're being rewarded for volume. So these are the core elements of fundamental healthcare reform that we work on at Catalysis. We're a 501c3 basically education institute that works with many organizations around North America and the world, and Europe in particular. And this is what we do. So what we try to do is get people together. Jack Billy and I, about 10 years ago, put together something called the Healthcare Value Network, which the University of Michigan is part of. And this is a peer-to-peer learning activity where we get together 20 times a year within different organizations that are all trying to learn how do we build this culture of continuous improvement using a core set of principles that came out of industry. And you can see some of the other things we're very excited about. The Center for Lean Engagement and Research at UC Berkeley, Steve Shortell, very famous organizational performance researcher, is the leader of that work. And so we're actually now doing translational studies and longitudinal studies on the use of the lean methodology in healthcare. So we're hoping to show some results soon. So we do have a perspective, and that perspective is that this work really is about creating systemic change. It's not about a bunch of projects. And in healthcare, we love to do projects. And the result of those projects has not been all that great, frankly. So what we really need to do is step back and say, how do we actually change the system? Because if we change the systems, we can actually improve and sustain the activities that we need to improve and sustain over time. So I want to just walk through. This is another house metaphor. This is the healthcare house metaphor. You've seen, those of you that have read Jeff Leiker's work and John Shook's work have seen their house or the Toyota house. But this is how we have, as we've really studied lots of organizations now trying to apply these principles, this is how we see the world. And it does start with sort of what is the purpose? Why do we exist? What have we defined that? What are the values, the belief systems that we have? What are the principles that we actually do our work together under? So is there a set of principles that we're applying to the work that we're doing? And then are we actually changing anything? So in the middle here I have a new operation system or a model cell, model line, dramatic improvement in some part of our work. So have we really gone in inch wide, mile deep to redesign the emergency room flow or the inpatient performance? On either side then we have an integrated administrative functions system. So, as human resources, as finance, as IT, are they all engaged with us to try to build this new system, this new model cell? And then do we have a problem-solving group of experts that can help us along the way as we're learning how to improve the performance of the system? Management system, I saw evidence of that today. I was in cardiovascular outpatient clinic. I was in the NICU and 5B med-surg unit. So I saw evidence of an emerging management system here. And then the leadership behaviors. And this is a thing that I see, when we work with frontline teams, the frontline teams are always excited to improve things. And if we give them the opportunity to do that, they do a great job. But what is the leader's responsibility in supporting those teams? And this is where I find in many organizations I go to, those leadership behaviors and expectations have not been clearly defined. So we don't really understand what our leaders are supposed to be doing. So I'm going to spend a significant amount of time on that today. What are those leadership behaviors that are important? But I want to step back for a minute because most of the organizations that I see trying to apply methodology of lean or operational excellence or TPS, whatever you want to call it, they start down here and they have a whole series of tools. And there are a lot of great improvement tools that we can use to get results. And many times you do get results using the tools. The problem is that if you only use the tools to get results, you don't sustain. And I heard some of that today as I'm out in my Gemba walks, that sustainment is the issue. Sustainment is the whole thing that we're focused on. So what I want to talk a little bit about is what we now know is important for sustainment. And it starts with up here on this triangle, which is principles and behaviors. I actually had the privilege to be on the same stage with the chief engineer of the Toyota RAV4, Mr. Sengason, and he basically, his whole talk was about one thing, and that's the behaviors of the leaders. Didn't talk about tools, didn't talk about value stream maps, didn't talk about anything other than the behaviors of the leaders and how he developed the leaders as the chief engineer. So what we know is that we have a set of guiding principles that drives a set of behaviors that we can start to build systems that, using the tools, we get results. And if we start from the top of this guiding principle side, that's where we start to understand the why behind what it is that we're doing. And that's the important part. What's the why behind how we're acting and the systems that we're building? So let's delve into the principle thing a little bit more. This work comes from the Shingo Institute in Utah, and it's based on work that was many of the writings of Shigeo Shingo, who was a famous Toyota sensei. He wrote several books and has been one of the key sort of drivers of the understanding of the Toyota production system. And so the Shingo Institute actually codified the thinking of Shingo into these few principles. We now know that these principles are critical to really developing operational excellence and a culture of continuous improvement in organizations, and it's been shown in many, many different industries now. So the first is creating, in our industry, is to creating value for the patient. So is everything we're doing focused on creating customer value rather than creating convenience for the rest of us? So number one principle, customer value, improve customer value. Number two, constancy of purpose. So back to the floor of that house, the bedrock, have we actually defined what it is that we mean by our key true north metrics, not 150 metrics like I saw in a hospital the other day, but 5 or 6. Have we actually identified those things? And then think systemically. So this is a very complex organization. There's lots of departments, there's lots of buildings. Actually, I think I got my 10,000 steps in this morning just by going back and forth between the Children's Hospital and the adult medical departments. But we need to think about the patient experience across the system. And that's how the patient experiences us. They don't experience us in our silos. In fact, many times that's part of the barrier for our patients to be satisfied, is when we have these complex things that we're trying to do to people, we're not designing it in a way that flows for the patient. So we need to really think about things from a system standpoint. The enable principles are more around the human side of this activity, right? So do we have a process in which we lead with humility? There's been an interesting set of research done in the last year or two on this concept of humility. There was a paper in Journal of Management last year that compared 125 tech companies and the CEOs of those tech companies. So were the CEOs humble or not? And they had some OD sort of assessment tools they used to figure this out. The companies that had humble CEOs were produced 3 times better results, both from a financial perspective and also from a process perspective than those that didn't. So leading with humility is an important activity. I'm going to talk more about that. Respecting every individual. So have we created an environment in which people can come to work and do work that gives their life meaning every day? That is the ultimate respectful environment. And then learning continuously. So as we find things that work, or more importantly, find things that don't work, do we have a mechanism to study and adjust? Are we really using PDSA thinking every day? So these are the key principles from an enable perspective, enabling the culture. And then we have the improvement principles, and many of you are very well aware of these: managing variation, creating quality at the source, seeking perfection, focusing on process, not the people, using scientific method, PDSA thinking, and then creating a process in which patients can pull from us rather than we pushing it on them. So we know that these principles, when they are utilized effectively, can actually be the bedrock for this journey. And if we're always going back to those principles, then we actually begin to build behaviors that make sense from the standpoint of sustaining a culture of continuous improvement. So let's talk about a couple examples. If we talk about purpose, I want to, this is a hospital in Canada, St. Mary's, and 6 years ago they started their lean journey. They're about an hour and a half out of Toronto. And Don Chilton, the CEO there, said, I want to make this the safest place to get care in all of Canada. So what the first thing they did was they created this very simple visual of basically 4 metrics. On the top of that metric, it was patient safety. And the top metric of that was we're going to eliminate preventable harm. So last year they actually achieved, the Canadian Information Organization, that's not exactly the right name, but anyway, the federal government in Canada has a measurement process they use, and Don Chilton, the CEO there, got a call from this organization saying, did you know now that you are the safest hospital in Canada? And they were pretty excited about that. Lowest infection rate, lowest preventable harm rate, and they had this newspaper article, and of course the idea was the flow of staff ideas. So tens of thousands of staff ideas were the reason for why they'd achieved this performance. You can see their hospital standardized mortality rate. So the question I asked Don was, this is the CEO, I asked him, so what did it take? I mean, what was the biggest barrier you had to actually achieve the unbelievable results that you've achieved? So what's the biggest barrier that you as the CEO had? And let's see what he had to say here.
So for me, biggest barrier was really having the confidence to tackle this, and the belief that we could pull it off. Going to Theta Care 2009, that was my first exposure to it. And wow, this is an amazing place, an amazing organization, how they've transformed. And it was really, could I do that myself back at my organization? That was my biggest barrier, convincing myself that we could really pull it off. And the way we did that was initially taking people from our organization, some of the really key people, to see. So Theta Care, other Gamma visits, we went to New York City, was very helpful. And then just trying stuff and being willing to fail. That was important for us, to be accepting of, we don't have to be Theta Care out of the gate. It's going to take us a long time. And I think that's really what has made it for us.
And of course, they achieved more than we achieved. So he's been a great example of the leadership that it takes to completely change an organizational culture. And so what we've found is that we published this article in New England Journal Catalyst about these 5 behaviors. And so what we've been doing is study. We have about 50 CEOs that we work with around North America now. And we've been studying what are the things, first of all, what are those behavioral traits that really allow people to sort of unleash the creativity of all of their workers. And Susan Ehrlich, who is the CEO of Zuckerberg San Francisco General Hospital, has been using this process that I'm going to describe to you to actually help mentor and coach the leadership team at the San Francisco General Hospital. And so this is what it looks like. And these different characteristics or behavioral traits have been studied in multiple industries. The first one is willingness, and what that means is the willingness to change your own behavior. And there are a series of reinforcing, observable activities that help to understand each one of these behavioral traits. So for the willingness to change, it comes down to self-reflection. Are we actually willing to, spend some time each week or every other week to reflect on how we're doing? To say what happened this week in terms of what I did with my team or with some frontline workers that unleashed the creativity of their ideas and problem solving. And what is it that I did this week that shut them down, right? Because we're our best critics. And so this process that I'm talking about is really a self-reflection process. What I've found is that some of the leaders, and by the way, you don't have to be a CEO to do this, okay? This is important for all of us. But what I've found is some people actually will put specific time on their calendar to do self-reflection. In one case, we had a CEO that was using a diary, okay, where he was reflecting. In another case, I'll show you Susan Ehrlich, where she's actually used a personal A3 process to self-reflect really every week, with not only with herself, but then to share that with her team. The second one is humility. So I already described this Journal of Management article. You probably are well aware of Jim Collins' books. He also studied this particular trait and found that companies that had humble CEOs were actually much more successful than ones that didn't. So what is the reinforcing behavior? It's to go and see. Dr. Bernstein opened this up with talk about going to see. Well, that's how we learn. That's how we get the facts. That's how we show our humility. Because the reality is, I was CEO. I'm an internist. I was a CEO. The fact was I didn't know the facts. Okay? I thought I had the answers, and I didn't. And where I got the answers was when I went to the place where the work was being done, where I went to the emergency room and I went to the ICU. So when we had a tough decision to make as a senior executive team, the most important thing I could do was to go get the facts, and that was where the work was being done. And so the reinforcing behavior of this behavioral trait is to go and see. And what was interesting is, as a leader, I went and I saw different things than as a clinician. Because as a leader, you go to look for, you're looking for, how are the processes working? What are the barriers our people face? What are their needs? And as a clinician, you're just going in there and doing it, right? Because you got to get it done. And it's a different type of thinking that you use. The other thing is, when I go to the GIMBA, go to where the value is created for the patient, I didn't have all the answers, and that was kind of scary, frankly, because people expected me to have all the answers. But the reality is, most of us as leaders don't have the answers, and what we need to do is ask good questions. So the next one of these behavioral traits is curiosity, and this was actually the interesting story here. It comes from actually an automotive example. So this was when the NUMMI plant was formed, which was a joint venture between Toyota and GM back in the early 80s. And the idea was that Toyota basically was going to share the secret sauce of the Toyota production system with General Motors. And they were going to do this in a partnership called the NUMMI plant in Fremont, California. Nobody really understood why Toyota wanted to do that, but it was like, great, okay, we'll take it. So the first thing they asked GM was, we want to go into your worst plant, the worst plant that you have in all of the world. Where is your worst plant? And of course the GM exec, no, we can't take it. We can't do it on our worst plant. That plant is really bad. And it was really bad. So this plant was, they had they were selling drugs on the shop floor, okay? That was one thing. And there were a whole bunch of other things. You can read about it. But I mean, this was a horrible plant. So the first thing the Japanese managers came in to do was they fired all the management. This is a bad plant, and we have bad management. So we're going to get rid of the management. When they rehired these managers, there was one thing that they were looking for, one behavioral trait, and it was curiosity. And of course, the point was they wanted people that actually were interested in how things worked and how the systems were working, right? And what are the systems that aren't working so that we can fix those systems and build a culture of continuous improvement. So if we think about what are the observable things that we might see if you actually were curious, one would be asking questions. And not the kind of questions that are, did you think about this, right? Not the kind of questions where you have the embedded solution in your question, right? But open-ended questions, such as, how do things work here? And how do you think they should work? So we want to ask different kinds of questions than we're generally used to asking. We want to ask open-ended what and how questions. We want to become effective listeners. And as my friend who's been here, I think many times, Margie Hagney says, listening is not waiting to talk. And that's unfortunately a lot of what we do, is we're waiting to get our idea in there because we have the right idea, and the reality is we don't have a clue. So let's step back and listen to the people that are actually doing the work to understand what their ideas are, because generally those people have the right solutions in mind. And then finally, A3 thinking. So on a single piece of paper, can we actually identify background, the current state, write a problem statement that doesn't have an implied solution in it. Just try to write a problem statement. Problem statements are hard to write, especially if you're trying to do it without putting your own ideas in there. And then what's the target we're setting? What's the root cause of the problem? What are the countermeasures? What are the things we're going to try? It's plan, do, study, act. There's a lot of posters I think you're going to observe tomorrow. Very simple plan, do, study, act. That's really all A3 thinking is. So again, these are the things, if we're curious, that we ought to be doing as leaders. And these are the things that people like Google and others actually hire for. The next one is perseverance. So, when we're trying to learn a different system, a different method, it's hard and it takes work, and not every day goes well. And so we need some reinforcing things. So one of the things that's important is to have a buddy. Somebody that can actually observe you in the work and give you feedback about how you're doing. So maybe it's a trusted colleague, maybe it's a teacher from the improvement office, maybe it's somebody else. But having somebody can observe you in terms of how you're actually doing the work is important. And then also somebody that can coach you. So someone, I always say, if you're going to learn to play the piano, what do? Read a book and then go play the piano? I mean, come on, what do? Get a teacher and practice, and practice, and practice, and practice, and practice. This is no different. The same concept. We need to practice these different behaviors. Practice the behaviors of going to see, ask questions, showing respect. Practice the behaviors of effective listening. And then finally, self-discipline. And this is where most of us fall down. Leader standard work. So the story I always tell about me and my standard work was my sensei teacher asked me, so have you looked at your calendar next week and determined whether there's anything that you're going to do next week that's actually going to add value to your patients? So I pull out my calendar, so when I'm CEO, and I said, there is nothing that I'm going to do next week that adds value. Nothing. Zero. I am zero value added. Okay? That's an interesting realization when you suddenly find that you're zero value added. But part of the reason was I hadn't actually created any standards, any standard work to actually identify things that I could do that would add value to the patient. So I think it's important for us to think about that. If one of our key principles is adding value to our patients, are we actually doing anything as leaders, managers, to actually do that? And take your calendar out next week and look and see what's going on. I heard a lot about meetings around here this morning. There's a lot of meetings I heard. Is that true? Yeah. How many of those meetings are value added to patients, right? You have to constantly be thinking about that. Stand-up meetings this morning, the huddles and that sort of thing. Actually, there were good ideas generated, problems identified, Maybe actually add some value in some of that. But the 3-hour meetings I used to have with my executive team, not much value added there. Okay, so let's go back to Don for a minute and take this framework now, okay, that I just discussed. What were Don's barriers, right? So these are the two things he identified. The confidence that the method would work. So this improvement method, this process, and then his fear of failure. Those were his two biggest question marks. So if we put that on the radar chart, right, what does Don need? Don wanted to run some experiments. First of all, he said, we're going to just try some things, right? So we're going to try some things. The things we're going to try, we're going to use the framework of A3 thinking to run some experiments. And we're going to see if this stuff actually works or not. And he did. He ran a whole lot of experiments. He and his team ran many experiments on infection-related issues, other things, and they got some great results. And then Don needed a coach. So Don did get a coach. And this is Don's coach. This is my colleague, Kim Barnes, who wrote the book Beyond Heroes. She really pioneered a lot of the early management system work. And And Kim has been working with Don for about 5 years. So Don needed to get confidence, right? So what he did was he went out and he got a coach to help him understand what it was that he was supposed to do as CEO. What does the standard work look like? What are the behaviors that he needs to apply? Many of them I've talked about. So here's another example. This is Susan Ehrlich. So she's the CEO at Zuckerberg San Francisco General Hospital. And we ask her the same question. So what's the biggest barrier for you to become this leader of an improvement culture?
So Susan, what was the biggest barrier you had to overcome to become a lean leader?
That is a really interesting question. And on reflection, I would have to say that there are really two reasons. One is an external reason, and that has to do with the dominant paradigm in healthcare, which is really all about firefighting. And so I would say every day there's a constant pull to firefighting in the organization. And one of my jobs as a leader, as a lean leader, is to make sure that we're pulling back and we're really focused on true north. And the second thing is really internal. And I would have to say that that has to do with me and my search for perfection as a lean leader. And it's really about inconsistently applying continuous improvement to my own leader standard work. And I'm very devoted to continuing to improve that. So in summary, two reasons. One is external, one is internal. And they both really require a lot of consistency and persistence of practice.
So Susan is an internist, and she has been working on her own standard work, okay? So her issue was leader standard work, right? So here's her leader standard work. Pretty impressive, I'd say. She's got her daily standard work, red, green dots, weekly standard work, monthly standard work. Here's the Zuckerberg San Francisco General True North metrics, the X matrix. Here are breakthrough strategies. I mean, looks pretty good to me. But she's not happy with it, right? So again, as we think about what is it we're trying to do, we're constantly trying to improve our performance, whether it be on these personal performance issues or organizational performance issues. The other thing she talks about is firefighting, right? So I'm firefighting. So what we need when we have firefighting is to, guess what, put some standard work in place, right? So this is an example of a management system process, set of processes, in which we start out with our True North metrics, quality, safety, delivery, cost, the key behavioral indicators. So again, back to the behaviors. Have we defined what those key behaviors are? And then a catch-ball system between all levels of the organization on performance, right? How are we performing to these behavioral indicators? How are we performing to the metrics? And this catch-ball system is then, built around visual management. I saw the visual boards today in the various areas. But are we having the right conversations up and down the organization? Because what we need to do is build these systems from top to bottom and bottom to top. So we're actually, the front line is being informed by the leadership, and the front line is informing the leadership. And that's what this catch-ball process is. It goes both ways. And at the Zuckerberg San Francisco General Hospital is exactly what they're working on, trying to build this process from top to bottom and bottom to top. And this is actually what she's posted on her door in her, at her office. So here's a personal improvement A3, becoming a model lean leader. So she actually has posted this. This is her, okay, very personal stuff. And she now is having all of her leaders do something similar to this. And then this becomes their development plan. So it's not only her development plan, but it's their development plan. And I think that's one of the best ways that I've seen these behavioral characteristics with the radar chart in the middle, right? So she's rated herself on these various things. But this is one of the best examples of how I've seen the actual personal development, behavioral development activity be exemplified. So let's move to the East Coast now. This is UMass Memorial, which is the large academics medical center in Massachusetts. And Eric Dixon, who's a good friend of mine, took this place over. He's an emergency room doc, and he took this over about 3 years ago. When he took over, he didn't realize that they were going to lose about $60 million that year, that they had a nurses' strike, and that they had a couple other things that were tearing the place apart. So within 2 years, this is what he did. Basically a $100 million turnaround. They went from losing 60 to making 50. And he's most proud of this chart, which is when he took over, this was the inpatient mortality. This is I think this comes from the University Consortium or Vizient. And here's where they are as of last week when I visited him. So pretty dramatic improvement here. And over that period of time that he's been CEO, there have been 50,000 frontline staff ideas implemented by frontline staff. So one of the reasons they've gone from here to here on their mortality rate is that they are implementing on a very rapid cycle improvement process the ideas that team members are coming up with to improve infection rates and other things. So, same question I asked Eric. What was the biggest barrier for you to become this great lean leader?
The greatest barrier I had to overcome to become a lean leader was myself. I have been an emergency physician for well over 20 years, and I like to walk into a room, I like to take charge, and I like to direct people about how to get things done, especially when there's pressure, especially when I feel a sense of urgency. And I bring that clinical background to what I did from a manager perspective, and that is the worst thing you can do as a lean leader. And that what comes out over and over again for me, and I've been able to overcome most of that, although I still have that problem inside me, by talking to the people around me that are on my team and telling them to signal me when I'm in that trauma doctor mode, emergency physician mode. And so there's multiple members of my team that I trust that will tell me, you're thinking like a trauma right now, when we actually have to take a deep breath and step back and hear what everybody else is saying. And I catch myself doing that every week. And that's the good news, is that I catch myself because my team helps me stop doing that. So it's been a great experience.
So Eric is at the Gimba every week, and he's out with the team members. So thinking like a trauma, that was Eric's barrier, which is, I think, was probably my barrier, and maybe some people in the audience have the same problem. So if we look at, again, if we go back to the radar chart and we rate ourselves, what was he after? He told his team to say, you're thinking like a trauma. So he gave them, the responsibility of helping him not be that way. And then, he's reflecting on that behavior and making changes. So each one of us, the point being here that each one of us has a different set of concerns. And as we think about what is our biggest concern related to these different behavioral traits, what is it for you? And you can use this simple radar chart to rate yourself, 0 to 5 on each one of these activities. And then you can also use it to, what I see this leaders doing is they go back every 3 or 4 months and re-rate themselves. So how am I doing, now compared to what I was doing 3 or 4 months ago? And what they find is that, one of the other parts of the radar chart is pulled in, and then they focus on that. So again, this is really a self-reflection mechanism for everyone to learn how to be a better leader. So we're back to this chart again. So guiding principles. So we've talked about guiding principles. We've talked about ideal behaviors. And now I want to talk a little bit about systems. So what are systems? One system is model cell system. So I want to talk a little bit about this. This is not an incremental improvement system. This is actually a radical change system. So this is where we're actually dramatically changing the work that we're doing, redesigning the work to get 50, 80, 90% improvements, not 2% improvements or 4% improvements, which are fine, by the way, as we think about daily improvement systems. But when we're talking about model cell or radical redesign, we're talking about major difference changes. So this is inch-wide, mile-deep work. We're going to completely redesign the emergency room. We're going to completely redesign the outpatient clinic. And we're going to do that creating a new system. We're going to make sure that we are actually able to obtain performance metrics that we've identified as important, called True North. And we have to have senior leaders engaged with us on this work. Here's an example. So this comes from the Muhlenberg Hospital in Pennsylvania. And I went there that day to look at Rick McKenzie's work. He's the emergency room leader there. And I took this picture of the emergency room. So there's interesting about this emergency room. There are 9 chairs in the emergency room, waiting room. 9, okay? This is a 75,000 visit per year emergency room. So relatively busy emergency room, 75,000 visits a year. And the day I was there, there was nobody in the 9 chairs, okay? So that gives you an example. Now compare that to the hospital that I went to, it was about 45 minutes from there. They had a pretty similar number, about 75,000. There were 65 people in their waiting room, and then there were 10 people standing in addition to the 65 people that were in the chairs, okay? So there's the difference. That's the visual, the difference. So I asked Rick McKenzie, these videos look weird because I take them with my iPhone, but I asked Rick McKenzie, so what is it about your emergency room that is so spectacular?
And the definition is a very flexible physical space that allows us to move from an intake team process all the way to a triage process and back again. It enables us to adapt with the demand and the capacity of the system that we're working on.
So this is what they were able to do. They needed a $24 million emergency room. The senior executive team said they could have 6. And they avoided $18 million in the redesign of this work. They had actually 50 hours of diversion each month, and that went to 0. Rapid assessment averaged 26 minutes, and time to treatment decreased by 30 minutes. These are radical improvements, okay? And that's what we're talking about when we talk about model cell. I want to show you one other radical improvement, and this comes from Seattle. This is Seattle Children's, their Bellevue Outpatient Surgery Clinic, which I've been to a lot of outpatient surgery clinics in my travels, but this is the best one I've ever seen. And it's designed with the patient flow in mind and lean thinking. So let's see what this looks like. And now I'd like to show you what good looks like at the Bellevue Surgery Center in Seattle. Seattle Children's Hospital designed their surgery center to focus on patient flow. As the patient arrives, it's easy to know that you're going to the right location. As the family arrives in the surgical unit, a greeter checks them in, and then, after a short wait, the nurse walks everyone back to the prep area. Here, the nurse begins by checking the vitals, then they move to the induction suite. Next, the doctor and anesthesiologist come into the prep area and talk to the parents and the child about the procedure and how it will go. The anesthesia is administered as the patient closes her eyes. The red light means the OR is still being prepared. Once the OR is ready, the light goes off. And then the anesthesiologist rolls the patient into the operating room. The surgery begins. The staff ushers the parents to the post-op room on the other side of the operating room. After the surgery, the patient is wheeled right into post-op. When the child wakes, the parents are ready to offer their comfort. The nurse comes in to record the patient's vitals and describes the post-op care. When ready, the family heads home to complete the recovery. I think every one of us in this room would like to have this experience for our children. It took them about 9 months of constant design work to actually create this flow. This flow has been very interesting. They've been able to increase the capacity by 35% without changing any staffing. So the flow itself has driven dramatic results at that place. So that's one of the systems we need to create. Here's another one, the performance improvement system, which is really a teaching center. So you have one of these, by the way. The team members are all here today. We want to develop single improvement processes, and we want to deliver results from the standpoint of creating leaders as teachers. So the improvement team should really be about, embedding these ideas and principles within all of you. We also need an innovation system, and in order to get really significant radical change, I believe that we need to focus on the process of creating innovation. When I was CEO, we had two great innovations, but I must say we were just lucky. We didn't actually have an innovation system. So the question is, what is the innovation system we need? We published this article on Harvard Vanguard Medical Associates from Atrius. My son's an engineer, so he's kind of geeky about all this. And this is when we walked into their Innovation Center unit, this is what we saw. The first thing you see is, how do we obsolete it? Now, if you're in the hospital business, that may not be such a happy thing to think about. But they aren't in the hospital business, and actually what they're trying to do is obsolete hospitals. But this is a system as well. So what is the system that you have to focus on innovation? And here's the article from Harvard Business Review basically outlines these core elements. But I do think it's a system, and it's an important thing for us to think about is, do we have a system to do this? Here's another system. This comes from Human Resources. This comes from Memorial Care in Los Angeles. Do we actually have a process by which we know all of our leaders are being trained to a set of competencies, right? So have we created that system? Another system, financial forecasting. I'm not going to spend a lot of time on that. Another system, business intelligence. Okay, this comes from Salem Health in Oregon. So as a nurse, I need a certain set of data so that I can improve something. So do we have an IT system that actually allows us to get the information we need? I saw in the NICU updated data for updated every 12 hours. That's impressive. This is the kind of process that we need to actually deliver performance. This was this was the data system that we had at ThedaCare, where we could actually see inpatient staff hours over time, so we could actually redesign the work and the staffing of the folks. So what we need? Principles, behaviors, systems. Take the tools, get results. That's the process that we now know works the best. So I certainly saw elements of that today, this morning when I was walking around. But frankly, I haven't seen the whole system put together yet by anybody. So I'd love to see the University of Michigan Health be the first ones to do it. So that's the end of my, I'll just leave you with this. It's true today as it was 5,000 years ago. So thank you very much. I think we have a couple minutes for questions.
So we do have about 5-10 minutes for questions. So any comments, questions from people in the audience? Jack?
Thanks very much for coming back to Ann Arbor. It's great to have you back again. The spider diagram with the attributes for effective leadership, that seems like a very practical, applicable strategy we could use in our organization. Is it ever, first of all, where would we go? I know the article that you wrote may be helpful to that, but you could mention it here. Where would we go to get the sort of grading paradigm? And secondly, is it ever used in a 360? Because my assessment of myself, we know in medical care, sometimes we overassess our own competence.
Yeah, so I will send it to you, or Gene, or somebody, and you can, I've got the scale and the definitions, all that. So we developed this as a self-reflection tool. People are using it in different ways, like 360s. In fact, I just talked to one of the leaders last week who is using it that way. That's not the way we designed it to be used, but you know what? I think you can do whatever you want to with it. It certainly is a potential tool to be used as 360. But the way that we really introduced it to leaders was for them to be thinking about their own behavior. And from the standpoint of what I think is most important, because most of us, when we get into leadership roles, we do have 360s. You know, a lot of organizational development work is done. But I think the thing that I'm trying to get across is that we need self-reflection time. This is a way for us to self-reflect. And, you know, shower in the morning and drive to work does not count, okay? I mean, we really have to make time. This is real work. If we're really going to change ourselves, you know, it's real work. I've also seen it where people will have their buddy rate them. So, you know, somebody goes out and observes you in the real work, and then they rate you, and then they sit down and have a conversation. But I think, you know, it's up to you how you want to use it. How we designed it to be used was simply as a self-reflection mechanism, with the intent being you really should do self-reflection. So, but we'll send it to you.
Other comments? Yes.
I was struck by the trauma guy who became the head of the organization. Maybe because he was, bigger than kind of guy. So do you see more often that organizations are appointing leaders because they get it done, and then you have to teach them these new behaviors? Or are there any models where you support leaders who are actually doing that behavior?
Well, that's a really good question. I mean, I think the longer that you're on this journey of trying to build an improvement culture, and the more that gets embedded in your DNA, the more you're looking for the leader that already is, you know, exhibiting these traits. But as we know, in healthcare, there aren't many leaders like that, right? So that means there aren't many organizations like that. Now, I think the next person who's going to lead, you know, these 3 organizations that I highlighted will have those traits, because those leaders are modeling the way to make sure that these traits are the things that are important, both from a, you know, from their development plans perspective, and from the standpoint that those leaders do model the way, right? But I think in traditional healthcare, it's basically an autocracy, and it has been that way for years. I'm going to tell you what to do, then you tell the next person what to do, then you tell the next person what to do. And we know that what that does is just shut down the creativity of the workforce. And if we ever needed a creative workforce, it's now. So I think we're going to see emerging organizations. There's, you know, I showed you examples of 3. There are many organizations now that are actually applying these principles. We just did a survey of American hospitals through the American Hospital Association. And we had about a 27% return rate of the survey. This is a very detailed survey, by the way. And in the survey, they found that the highest likelihood methodology to try to be applied to develop, to improve things was the use of lean thinking. So I think as we get more people engaged and involved in the industry, we're going to see that the expectations for leaders is changing from, you know, I'm the problem solver to I'm the developer of people that solve the problems. And that's really what we're trying to achieve in this thinking process. But we're not there yet by any means.
Okay, and to allow everyone to stay on time, we'll be wrapping up now. I'd like to give Dr. Toussaint this small token of our appreciation. It's a Michigan hat, which after Saturday's football game, maybe he doesn't want to wear. But he is from Wisconsin, so at least UW is doing well. And
Nobody take a picture of this. Thank you very much.